move on to some basics about pain. As Rajalakshmi told, we have to make it very interactive. So I will share my screen. Okay. So I'm directly going into the session. We will start with a real patient story. Okay. I hope you can see this photo of a patient. If this patient comes to you, what would be your primary concern, or what would be that bothering you when this patient comes to see you? Anybody, quick answers?
So the tracheostomy, which is uncomfortable.
Yeah. Anything else?
And the pain, so he's having the expression of pain on his face.
Okay, you can also give your response in the chat. Some more response, please.
We have to ask from the patient.
Yeah.
What is the main concern of the patient? I mean, why is he so?
Yeah, that's important. But from his facial expression, what do you understand?
He is in intense pain, it seems.
Okay. As medical professionals, I think our primary aim should be able to understand what his face is. So from his facial expression, we can understand that he is in severe pain. Tracheostomy is there, but that's the secondary concern. Yes. Okay. This patient is a 54-year-old man with carcinoma of the larynx. And you can see he has undergone a tracheostomy. And actually, he came to us with his 84-year-old mother. And his radiation and chemotherapy was over. And he is not taking any active treatment. And because he has a progressive and advanced disease. Now his main problem is pain around neck, and he is also complaining of pain on the right upper limb. Okay. So next question is, how will you evaluate the pain of this patient? So here we are going to take you into breakout rooms. You will be grouped into 4 groups. And you need not do anything. Rajalakshmi will group you so that you will go into corresponding groups. And in the group, you have to discuss this. How will you evaluate the pain of this patient? You have to actually select one leader from each group, and that leader will be telling the feedback of that group. I hope it is clear. So please select after going into the groups, each group will select a leader, and then you discuss how will you evaluate the pain of this patient. You will get 7 minutes.
Yes, sir. We can close it by end of 5 minutes, 5 to 6 minutes. Like sir said, we are dividing it into 4 groups. We have around 40 participants right now. So we are dividing it into 4 groups. So around 9 to 10 people will be there in one group. First thing, identify a leader. The leader have to note down all the discussion points regarding what is happening in the group and just have a brief about it after you leave the room. So I hope we are all on the same page. Can I divide into rooms?
Okay, I hope you had a very good discussion among your group. So I would request first the group 1, what did they discuss? How are they going to evaluate the pain of this patient?
Yes, sir. From what we've covered from our discussion, uh, basically going through main clinical aspects of how we find out from the patient, as we've learned about the onset or duration of pain, the quality, the intensity, and the site. Basically focusing on clinically how we can evaluate pain and trying to assess whether we can find a cause to that pain, how it affects his daily activities, the degree of the pain, the intensity of it, and going back to quantifying the pain. A good scale would be used by WHO from grading it from 0 to 10 based on how much the patient can bear. And even certainly if the pain can affect him physically, it can also affect him emotionally and psychologically. So we have to assess those aspects as well, how much it affects him, and maybe if he vents it out on his family members as well. So the mental stress associated with that. And specifics to this patient, considering his laryngeal carcinoma post radiotherapy and chemotherapy, the effects of the treatment he's already been through. So certain effects like laryngeal edema, difficulty in swallowing, and nutritional deficiencies, mucositis that can be caused by the treatment itself. So to find out the exact cause of what his pain is, the different aspects of pain, and to holistically treat it, not just bombard him with painkillers, but to also see what the cause behind it is, and monitor the effect of the medication we're giving, or if he's already on a particular treatment. If he's previously on some pain relief, is it working for him? Should we alter that? And are we missing anything in that treatment research? I hope I haven't missed anything from the discussion, but I think broadly we could summarize those points, sir.
Yeah, thank you, Dr. Jogan. That was that all were very good points. Group 2.
Hello, sir.
Yes.
Sir, I'm Harsha from Group 2, Room 2. So we had 10 members, and as a result of our group discussion, we actually came to some 5 to 6 points. Actually, first one is according to seeing the patient itself. The first thing that according to the visual analog scale itself, that pain scale in which 0 to 10, we can ask the patient what to feel, and according to the numeric grade, what number can you give to your pain? I mean, to the patient's pain. First is that, and second one, as you told, the patient was accompanied by his mother, a little old mother. So we can ask the mother bystander, how is the history of his daily activities? How means that all will affect the pain of the person and his quality of life. So we can ask whether he is sleeping, or what is his food habits, and how is he able to have his food, and assess his daily activities. And also we can assess his physical activities, like what all he's able to do, what all he can do, slight things like main things, eating, sleeping, those things itself. History, we can ask him also. And as a resume, he's a CA larynx patient, so he may have his difficulty in speaking also. So we can also ask him to write down the things, because he may not be able to convey the message properly to the patient. So we can ask about writing and describing his pain in his own words, in his own method. And along with that, we can ask the relieving factors, if any posture or if any position that makes him, means he had his upper limb pain and neck pain. So if anything is making him relieve the situation, and what anything that makes aggravating the situation, increases his pain, or is there any factors that increases or decreases his pain. And about somatic pain, like any other type of pain he's having with it. And his communication, like is he able to communicate, and is he able to tell his basic pain to his home members itself, like his family itself. So these are the small, little points that we had in our discussion.
Yeah, good points. Excellent. And next group.
Okay, so it's going to be like, first we are going to ask him exactly the site of the pain, like where exactly it is paining, and if he's not able to express, we can give that anatomical picture where we can point out exactly that this place is paining, because we may not be able to communicate. Then we are asking the duration of the pain, since how long it is paining, I mean. And whether the intensity of the pain, I mean, the type of the pain, whether it's pricking or it's stabbing or it's burning, and whether the pain is referred, I mean, whether it's really in that particular site or it's referring to his hand. And we'll also ask him whether the pain is very superficial or very deep, and whether it's affecting his food, because of the pain is not able to sleep or is not able to move to the toilet, or any daily activities or daily functioning is affected because of the pain. And next also we'll ask him, then we'll show the numerical scale also from 1 to 0, where 0 there's no pain and how severe is the pain. We'll show the visual analog also, where the expressions of the pain are there. And we'll have, because of the pain, whether his relationship is affected, I mean, because he's like angry or upset or he's withdrawing himself, or is he able to communicate about his pain, I mean, like he's able to express freely to his mother about his pain, or we can ask the relatives also. And the aggravating factors and the relieving factors, and whether he's on any medicines, and any psychosocial impact because of the pain, or any present medications he's taking for the pain.
Okay, thank you, group 3. Very good points. Group 4.
Hello, I'm Dr. Shanti. So from our discussion, we think the intensity of pain we can analyze by looking into the visual analog score, and his facial expression also we can assess, and we will get an idea. Then his caregiver is his mother. So from the mother, we can ask about his daily activities and how much his activities are restricted and all. And we all feel that the mother, the 84-year-old mother, is being his caregiver, means that itself would have made him broken out or psychologically upset or something like that. Then regarding the other fact, we have to look into the factors like the diurnal variation of pain, and how much appetite is there, and is it affected, the site of pain around the neck and upper limb. So the etiology can be different. The nature of pain also can be different, that we have to look into. And what all pain medications he was getting so far, what all things he has received, and what else we can offer. And then what are the aggravating factors, relieving factors, and such things. These were our discussion points.
Okay, thank you. All of you are correct. Now we will move on to more details about pain evaluation. In the pain evaluation, before that, I would like to ask you this question. Somebody please answer.
Sir?
Patient.
Patient, sir.
Okay, so that's the most important thing that we have to understand, because many times when we start speaking to the patient, the family member will interfere and they will be giving you the details. Then we will tend to listen more to the caregiver rather than the patient who is really experiencing the pain. Okay.
If the patient is not able to speak, sir, then
then we
we'll have to ask the caregiver.
We have to look for other things like facial expression. How are they vocalizing? There are many things that we have to look into.
Because this particular patient has a tracheostomy, so he will not be able to speak.
Yes. Okay. Yeah. Generally, that was in a verbal patient. Okay. So this is the revised IASP definition of 2020. So it has some difference from the previous definition, and it says it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So all of us know pain is not a pleasant sensation, and the person who is experiencing will tell us what is the experience of that pain, and how the person speak about the details of the pain. It is from his experience. From childhood onwards, we are seeing how our parents are expressing pain, what are the words they are using to express the pain. So we are learning how to express pain. Okay. The most important thing is pain is a personal experience. So it is a subjective experience, and the subjective experience can be modulated by various factors like psychological problems, social problems, financial problems, spiritual problems. And suppose if we after examination and history are not getting anything that we think is not contributing to pain, even then if the patient is telling that I have pain, we should believe that patient. Usually what happens when the patient comes and tell you that I have pain, first on the first consultation we will look into more details, but we are not finding anything. And after 2 or 3 consultation, and then when we see the patient, we will know, okay, that person is coming. I don't know what is happening. He may have some psychological problems. So we will ignore the pain and we will refer the patient to some psychiatrist. It is not true. So we have to actually find out, or we have to believe the patient that he has pain. So it's our problem that we are unable to find out what is the reason for pain. Maybe psychological problems or something like that. Okay, so you can go and read this article. I have given reference. So pain evaluation includes all this. So first of all, we have to take a detailed history, then specific questions related to pain, and explore other symptoms, psychosocial and spiritual suffering, examine the patient, and investigate if needed. So in the history, we know that when the patient starts speaking, many of us will interfere because of the time restriction. If the patient, if we want to actually get a good history, we should not interfere when the patient talks. And usually it is told that after every 15 seconds, the medical professionals interact the patient. So it is very important. And we know that some comorbidities like diabetes, they may have peripheral neuropathy. So it is important to get the history of comorbidities, and some medications like chemotherapeutic agents, it can produce peripheral neuropathy. So these all are important in the history. And what are the specific questions related to pain? You can remember by mnemonic. There are various mnemonics, but I will show you one. Location, L for location, D for duration, P for palliative and provocative factors. Palliative factors are those factors which reduces the pain, and provocative factors are those factors which increases the pain. Q is the quality of the pain. So patients may describe pain as burning, stabbing, lancinating, shooting. So all those are quality of the pain. Then R, as the pain radiating to somewhere else. Then S is the severity of the pain, for which all of you have come up with many scales. And T is the temporal factors. Temporal factors are time-related factors. Is your pain more at night? When you take tablets, how long it subsides? All those factors can be fit into temporal factors. So LD, PQ, RST. This is one mnemonic, and there are many others. Okay, and many of you have talked about effect on ADLs. So activities of daily living. What is the effect of pain on activities of daily living? This is very important. So we can understand how much the pain is affecting the patient. And you can also ask, what is the meaning of the pain? You might have heard that, okay, this pain is because I have, this is because of the curse of the goat, or this is because of the past sin. So, or I understand that I have severe pain now. It is because I have stage 4 cancer. It may not be true. Because the stage and pain of the cancer does not actually correspond. So these are the meaning of the pain. So if you think that, okay, there is something need to be corrected, that can be corrected. And briefly going into the pain pathway. So all of you know that this is the dorsal root ganglion, and dorsal root ganglion has peripheral process which ends in the peripheral nerve endings or free nerve endings, which are known as nociceptors. And the central process ends in the synapse in the dorsal horn of the spinal cord. And from the spinal cord, it crosses to opposite side and it ascends as lateral spinothalamic tract and it synapse in the thalamus. And from the thalamus, it goes into the somatosensory of the area of the cortex. And from thalamus, there are various projection to amygdala and various other structures. That's how emotions also affect pain. Okay. So these are the four processes that occurs during pain or nociception. Okay. First one is transduction. Transduction is the formation of the impulse at the site of the injury. When you have an injury, at the site, there will be a lot of chemicals released, which are collectively known as inflammatory soap. And the main chemicals are prostaglandin. So you know the importance of prostaglandin because NSAIDs block prostaglandin and thereby reducing pain. So prostaglandins, bradykinin, potassium ion, hydrogen ion, there are various things. So these activate the free nerve endings, which are known as nociceptors and produce an electrical impulse. And that electrical impulse will be transmitted through peripheral nerve to the dorsal horn of spinal cord and to the brain. But there is some modulation, that is modification of the pain impulse will be happening. So modulation mainly happens by descending pain inhibiting system. So descending pain inhibiting system, these are descending pain systems which descends down from the pons and medulla to the dorsal horn of the spinal cord, and that will help to reduce the pain. In addition to this, there is endogenous opioids which are produced in our body that will also help to reduce pain. And we also understand that other physical problems, psychological problems, social, financial, and spiritual problems can also affect pain. So all these are factors which can modulate the pain. And after this, whatever reaches the somatosensory of the area of the cortex will be perceived as pain. Okay, which is known as perception. So this is the dorsal root ganglion, which has a peripheral process with ends in free nerve endings. This is free nerve endings. And if pain is due to stimulation of peripheral nerve endings or free nerve endings, it is known as nociceptive pain. And if it is due to stimulation of peripheral nerve, spinal cord, or brain, is known as neuropathic pain. So pain can be broadly divided into two types, nociceptive pain and neuropathic pain. But we have to understand that most of the pains are mixed type. So this is how we classify pain, nociceptive and neuropathic. Nociceptive pain can again be divided into visceral and somatic pain. So we will briefly look into what are the features of this. So we know that pain is visceral pain. It is usually when you ask the people, they will not be able to localize where the pain it is. So it is called as poorly localized pain, and it may be a referred pain in case of cardiac or liver capsule stretch. It may be intermittent crampy or colicky in case of bowel obstruction. And sometimes it may be accompanied by nausea and vomiting. So usually visceral pain is intermittent if it occurs from the bowel. Somatic pain, soma means external parts of the body. So a pain which is arising from the skin, muscles, and bone can be included in somatic pain. So it is usually a more localized pain, and is the character is usually aching, gnawing, deep, dull, sharp, stabbing. These are the quality of the pain. And sometimes the position will exacerbate the pain. So these are the features of somatic pain and visceral pain. And now we will move on to neuropathic pain. How will you differentiate neuropathic pain? So first of all, we have to see what is the distribution of the pain. If it is a neuropathic pain, it will have neuroanatomical or neurodermatomal distribution. So if it is because of involvement of thoracic 10th nerve. It will be, the pain will be at the level of umbilicus. And so that is the distribution, neurodermatomal distribution. And quality is usually burning, lancinating, stinging, or electric shock like. Then the another important feature is abnormal sensation. The abnormal sensation can be either decreased sensation or it can be increased sensation. So decreased sensation can be numbness, whereas increased sensation is allodynia or hyperalgesia. What is allodynia? The stimulus.
Pain due to stimulus, which is generally not painful.
Yeah. So when somebody says, when my cloth touches my arm, it produces pain. That is allodynia. And hyperalgesia, pain.
Increase sensitivity to painful
Yeah.
stimulus.
Yeah. The stimulus which produces pain and it causes more pain. So suppose when you take insulin, it can produce some amount of pain. But if the patient perceives more pain, that is hyperalgesia. And the response to analgesic. Usually it is said that the response to conventional analgesics like NSAIDs or paracetamol will be less if it is neuropathic pain, but it is not must. And you can also get a history suggestive of a lesion or disease affecting somatosensory nervous system. So suppose somebody says, I have burning pain at the area of the chest. And when you take history, you say that the patient says that 6 months back I had some lesions in the particular area, and he says it is herpes zoster. So you understand that there is a history of a lesion, a history of a disease affecting somatosensory nervous system. So it is also important to get such history. So these are the 4 points by which you can differentiate neuropathic pain. So how to measure severity of pain? All of you know this. So can you just click, you will see some choices in your mobile or your device. And can you name the scale? This is, you will administer the scale. This is, you are not showing anything to the patient, but you say that you have pain. To measure the intensity, we are telling a pain scale in which 0 means no pain and 10 means worst imaginable pain, which is the scale. Okay, we will move on to numeric. We will move on to next. We will come to this last. Okay. Let me close. Close.
Visual analog scale.
I think it's numeric. We will give the answer in the last. Okay. We put. So this scale you will show to the patient and will tell that at one end no pain and the other end is worst imaginable pain, and you are asking the patient to just mark where your pain is. Some patients may not be able to give you pain in the pain scales. So you will ask this. whether you have no pain, mild pain, moderate pain, severe or excruciating pain. Which is this pain scale?
Categorical.
Okay, we will move on to next. Okay, so this is what is the scale? I'm not giving you any explanation. Okay, thank you all. So this is Wong-Becker's Facer scale, which is a non-verbal scale, which is used in children. Okay. And this is known as categorical pain scale, where you will ask the patient, do you have mild pain, moderate pain, severe pain, or excruciating pain? This is actually you are showing a scale to the patient. This is visual analog scale. And there is no scale. You are not showing the patient, but instead you are telling the patient. So this is numerical pain rating scale. Okay, in addition to this, there are many types of hundreds of scales which has to be used in specific situation. So I have given you some scales which you can read. And in non-verbal patients, and especially those who have cognitive impairment, we will mainly look the expression, facial expression, or how they are vocalizing, what are the changes in body movements and interpersonal interactions, and is there any changes in the activity, how are the mental status, etc. So this is the non-verbal things are usually incorporated into this pain scales. Okay. And you can see a body chart can be used for marking the pain, so that even if you are not there, another person can see where the pain exactly was the last consultation. And it will be useful. You can actually write LDPQRST in the side of that body chart, so that by look, you can get all the things about pain. We talked about history and the specific questions related to pain. And in addition, we have to look into other problems. So you already, many of the groups told that other physical problems need to be looked into. So patient has a wound near tracheostomy, patient has cough, decreased sleep, or this can actually aggravate patient's pain. And there are psychological problems, because you know that he came with a 84-year-old mother, and that is because his wife left him, because she after knowing the diagnosis. So he is actually worried about his wife, and about 84-year-old mother, and loss of his role in the family as well as in society, disfigurement due to tracheostomy, anger against medical professionals, because the oncologist told him that, okay, sorry, we will not be able to provide any curative treatment. And so he has hopelessness. So all these are going to exacerbate his problems. So psychological problems, social and financial problems. So he was unable to go for work for the past 1 year. So how are we going? How is he going to earn? There is no income. So that's also a problem, and nobody is coming to visit him, and he is unable to go out. So feeling of isolation. All these are social and financial problems. And spiritual problems. He's asking why God is, why have God given this to me? I have not done any sin in the past, but still this the severe pain is there for me. So these are all spiritual problems for the patient. So it is important for us to understand all this need to be assessed in pain in addition to LDPQ RST. So we know that physical pain, it will be modulated by other factors like psychological, social, financial, and spiritual problems. So it is important for us to understand this. So which component is usually addressed in the hospitals? It is usually the physical pain. But by addressing that only, we will not have proper pain relief for the patient. So we have to, actually we can see the physical pain. So this is an iceberg, and you know that only tip of the iceberg will be seen. So it's like pain is also like this. The physical problems will be there in the surface, but we will not be able to find out the psychological problems, social and financial problems, spiritual problems. So only when you find out those and then treat the pain, you will be able to give proper pain relief for the patient. I will be showing a 3-minute video now, which is by our program director, Smriti Rana.
In palliative care, we have this notion of total pain, pain that takes into account the life circumstances of the patient that contribute to his or her experience of suffering. I came across that concept quite early in my life, and I mean, in my career, and I thought I understood it, theoretically at least. And then one day, the home care team that I was a part of was called in to see this fisherman in one of the outlying villages of Trivandrum. We parked our van some 400 meters away, made our way down this narrow, undulating path. We could hear this man's screams well before we got to his house. And on approaching the house, we were assaulted by this stench, which made me gag. And when we entered his home, we were met by this helpless young woman, and behind her on the bed, a man in his 40s, who was the source of the screams. He had a myriad problems and a feeding tube. And on closer examination, we found that he also had a bowel obstruction that was not allowing him to pass what his wife was so diligently feeding him because she didn't know what else to do to look after him. And as a result, he was regurgitating his own waste. It was awful. Anyway, he was cleaned up, analgesics and other medication were administered, but no matter what we did, his pain would not fall below 6 on the pain scale, which is essentially a scale of 1 to 10, 10 being the highest, where we ask people to score their subjective pain. So finally, this benevolent and wise doctor that I have the absolute privilege of calling my mentor, he took this man's hand in his own, and he asked him, he said, "What's your biggest concern right now? What is bothering you?" What an odd question, I thought. I mean, the pain, the humiliation, the despair, and just the misery of everything that he was experiencing. I mean, the answer was glaringly obvious to me. The man didn't say anything for a long time, and I started to get fidgety. The silence was starting to get awkward and strained, to me at least. But the good doctor, he held steadfast. And after about 6 long minutes, and I know this because I was timing it, this man very softly said, "All I wanted was for my children not to be fishermen. And now they're going to be just that." He knew he was dying, and he knew that his wife would not be able to support the children on her own, and this one fact was causing him far more agony than anything else that he was going through. So one of the things we strive to do in our program is to undertake the educational needs of children from disease-ravaged families that can no longer afford to send them to school. But this process takes about a week from when the child has been identified. In this case, however, we sped up the processes. Donors were found, pledges were made, documents were signed, all to see these 2 children, aged 8 and 10, through to college. We returned to the fisherman's house the next morning, and he was asked what his pain was. Still 6, he said. He was then shown the documents, and he was told, "It is done." Your children will not be fishermen. The transformation on that man's face was magical. And once he had digested that information, he was very gently asked one more time, "What is your pain now?" 1. He died 3 days later, pain-free. And that, my friends, is total pain. And that was when I truly learned my first lesson in being still and allowing.
So I hope I need not explain what is total pain. It should be clear by now. Okay, so I just want to summarize what we have talked. We have to understand the detailed history, specific questions related to pain, explore other physical, psychosocial, and spiritual suffering, examine and investigate. And we have to understand whether it is a nociceptive or neuropathic pain. And we already talked about what are the features of nociceptive visceral and nociceptive somatic pain and neuropathic pain. Okay, so now we want to manage pain. So this is the basic principles of symptom management for any symptom. Okay, it is not only for pain, but also for any other symptom. You can assess the symptom by this. There is a mnemonic. Okay, EMA. So first E is for evaluation. So we have already evaluated the pain. Now we have to explain it to the patient by their words. They have to understand why there is pain. So many people will think why I am having pain. So they don't understand. So we have to explain it by simple language. Then we have to manage the pain. Management includes correct the correctable, non-pharmacological management, and pharmacological management. Then monitoring. So we know that after we give some medication or some non-pharmacological management, we have to, next time when they come, we have to monitor the patient. Then we have to give attention to details. So this video which we have seen is something which have given attention to details. Otherwise, we may not have got those important concern of that patient. So it is important to know the what are the problems or bothering the patient. So you can see that mnemonic EMA: evaluation, explanation, management, monitoring, and attention to details. So we know that in the management, we are going to use analgesics. So there are some important principles while using analgesics. So as far as possible, give medications by oral route so that pain will be less. Otherwise, if a patient has pain and you are continuing to use some IV or IM, it is going to cause more pain for the patient. By the clock, you have to give medication as per duration of action of each medicine. If the patient has continuous pain and you are giving paracetamol SOS, it is not advisable. It is not pharmacologically correct. You have to at least give paracetamol 6 to 8 hourly. Oh, sorry, 4 to 6 hourly. So that's what by the clock means. And by the ladder means you have to give pain medication according to the WHO analgesic ladder. And individualized treatment. From this video and from this session, we can understand that even if patient may say that, okay, I have this much pain, somebody says 8, and Rajlakshmi also says my pain score is 8, but our psychosocial concerns will be different. And if you give the same medication for us, it is not going to fit for us. So it is important to individualize the treatment. Okay, and I will finish with this WHO analgesic ladder. So this WHO analgesic ladder was put forward by WHO in 1986, and that was in for standardizing the cancer pain treatment. But now this pain ladder is used for treating all types of pain. And you can see it is 3 steps. The first step is for treating mild pain. Second step is for treating moderate pain. And third step is for treating severe pain. In the first step, you can see there are 2 drugs, non-opioid plus or minus adjuvants. So what are the non-opioids? Anybody?
NSAIDs. NSAIDs.
NSAIDs, paracetamol.
Yeah, NSAIDs and paracetamol. And what are adjuvants?
Tricyclic antidepressant.
Amitriptyline.
Physical therapy.
What is the definition of an adjuvant?
Antidepressant.
Okay, adjuvant is a medication whose primary action is not pain
Not
relief,
analgesic.
but is helpful in some painful condition. So whose primary action is not pain relief, but is helpful in some painful condition. That's what antidepressants do. The primary action is antidepressant action, but it is helpful in neuropathic pain. That's how it becomes adjuvant. Likewise, anticonvulsants. There are many adjuvants which we commonly use in pain management. Okay. And in the second step, you can see it is opioids for mild to moderate pain, plus or minus non-opioid, plus or minus adjuvants. So what are the opioids that we can use to treat mild to moderate pain?
Tramadol.
Tramadol, tapentadol.
Yeah, tramadol, tapentadol, codeine. These are the opioids which are available in India. And codeine is not usually used now. Tramadol is being used by many. And in the third step, we have strong opioids or opioids for moderate to severe pain. Opioids for moderate to severe pain. What are those?
Morphine and fentanyl.
Hydromorphine.
Yeah. What are the strong opioids available in India?
Morphine, fentanyl.
Morphine, fentanyl, and methadone. Okay, methadone is also available in India. So these are the 3 medications which we can use in the third step. So we are treating the physical pain, but we know that the physical treatment of pain has to be along with the psychosocial and spiritual support. Then only the patient will have proper pain relief. So you have to give proper psychosocial support, maybe with the help of community involvement or with the help of medical social worker. So somebody has to be involved. Okay. So if the patient has severe pain, you can directly move on to step 3. The patient whom we saw, he has severe pain from his facial expression. And if you asking, he will definitely tell that he has severe pain. So you can directly use step 3. And if the patient has moderate pain, you can use step 2. You need not start on step 1 and then after 3-4 days move to step 2. Then after 3-4 days to step 3. It is not needed if the patient has severe pain. Okay. So this is the WHO analgesic ladder, and I think we can stop here. Is there any questions? Anybody?
So what are the suitable adjuvants we would use for neuropathic pain in patients with just generally, if you will?
Okay, usually used adjuvant analgesics for treating neuropathic pain are tricyclic antidepressants and anticonvulsants and SNRIs, serotonin and noradrenaline reuptake inhibitors. These are 3 groups of medication which is commonly used, but in that also commonly used one are tricyclic antidepressants and anticonvulsants. You have a class on adjuvants. slides presentation. I think we can move on to patient story. So today's patient story will be presented by Dr. Ravindran.
Hello, am I audible, sir?
Yes, you are audible, sir.
I had a problem with it myself. I just joined after an half an hour process.
Okay.
Shall I proceed?
Yes, sir.
Good evening to you all. I'm Dr. Ravindran. I'm the medical director of Malabar Cancer Care Society. It's an NGO involved in cancer screening. It's not a treatment center. It's in Kannur, Kerala. And I am also the president of Payyanur Pain and Palliative Care Society. In fact, I am staying in Payyanur, and I'm a medical my associate with the MCCS for the activities. Okay, sir. Next slide. My case today is one my friend, 57-year-old. He is a BD worker. He is a male. He diagnosis was cancer of hard palate, T4, N1, M0. Next slide. His complaint was it was a unilateral foul discharge from the right nostril and frequent epistaxis, mild, not torrential, so that it was ignored most of the time. And constant dull ache. There was no severe pain on the right side of the face. There was one episode of blood from the oral cavity also, but it was assumed to be because of his poor oral hygiene. Next. So the history of illness was recurrent episodes of rhinitis, nasal block, nasal discharge, more on the right side, often foul discharge, foul smelling, for about 6 months or so. As I said, nobody gave his problems because he was a smoker and alcoholic. He had a prior episode of unexplained blood from the oral cavity, which was assumed to be because of the poor oral hygiene and gingivitis. It turned out to be that he had a granuloma in the palate that time. Headache, not severe, but dull aching, almost constant, more on the right side. He was heavy smoker, 15 to 20 BDs per day for about 25 years. Alcohol usage regular, but not heavy. Next, please. Examination, there was a granuloma on the hard palate, very small. It was initially diagnosed as nicotina palatii. Later, we on biopsy also decided it was originally the primary lesion. Direct nasal endoscopy was done. There was a growth on the right floor of the right nasal cavity. It was bleeding on touch. It was biopsied. SPR came out as squamous cell carcinoma. He was referred to, this was in the local hospitals done. Then he was referred to Malabar Cancer Center. It's not my Malabar Cancer Care Society. This is Tellicherry Malabar Cancer Center, which is a center akin to our RCC Trivandrum. There, the HPR was confirmed and the staging workout was done. And the final diagnosis was CA hard palate with extends to right maxilla and right medial canthus, T4, N1, M0. Next, please. Treatment was investigation. CT had to assess the external disease and cardiac evaluation was done. Originally, I think they planned chemotherapy after the radiation also, but it turned out after the treatment was palliative radiation. He was a difficult patient compared with the treating doctors. Somehow he completed 10 cycles. And the patient responded very badly to the treatment. And as per his wife's words, he was as good as dead when he completed the 10 cycles and he was discharged. 9th May, this is in 2016. April 2016. 9th May, he was referred to as a palliative unit. 9th May 2020, our palliative unit visited his home. That's about 6 days after discharge from the MCC. He was totally bedridden, emaciated, dehydrated, severe mucositis of mouth and oropharynx, perforation of the larynx, naturally because of radiation, and probably the disease also, was being fed orally with sips of liquid food. Nasal regurgitation and leaking through the nasocutaneous fistula near the medial canthus made feeding a torture. Patient was moaning in pain all over the head, not past motion for about a week. We gave an enema, and in the same visit, we gave an enema, IV fluids with the multivitamins, educated about the feeding style, like being fed sitting up, using straws, and adding special diet like eggs, meat, soups, etc. Started on morphine 2.5 for hourly instead of ultrasound, which was taking. Nurses and volunteers visited more often to hasten the recovery of the patient. Morphine dose had to be raised to 5 milligram and then to 10 milligram, and valproate sodium made him totally pain-free after 8 or 10 days time. Next, please. He is an employee. He was an employee of. He is an employee of Dinesh BD. He started working right now. That's right. Dinesh BD company started as a BD maker and rose to become an overseer. Wife is a homemaker. 2 children. Daughter married with 2 children. Son works as a head load carrier. On our request, the daughter, as soon as we intervened and requested her daughter to come home and stay with his father for a few days during the most difficult days. There was a very good family support from the daughter, son, and the presence of grandchildren was really good for the recovery of the patient, we believe. Visits by our palliative team was very beneficial. It was, in fact, it was more often than usual. The pain part has been conquered. The next distressing part was the palatal perforation and the nasocutaneous fistula. We took the initiative to take him to the nearby dental college, that's Pariyaram, now the government medical dental college, to have a palatal occlusion process is fitted. That changed the whole outlook of the patient on his life. He now visits our clinic on his own regularly and is off morphine for more than the last two years. No pain tablets. Medications right now only for diabetes and hypertension, nothing else. Main concern, of course, the threat of recurrence. There is there. They know it. And we have not given any false prognostic promises. It's almost 5 years now. Our prayers are with the family because we welcome get such happy ending experience. Let's hope it will be a happy ending story. Okay, next. Summary again. What we have the pain relief and the self-esteem with the help of that processes. That he could come out, he can be a social being again, and definitely the family bonding and the support, and definitely something beyond ours, the divine intervention. Next, please. Yes, the points to be discussed are pain, community support. Community support the family. Also, it's because of the family, our palliative team, the volunteers, and through them, others who visited them, who gave them support. That helped a lot in his recovery. And seek solutions. The problem for us, a problem, definitely there will be a solution. Solution may not be the apt one and may not be the final one also. But you can't keep on seeking solutions. Just the reassurance that there are people to help them out itself is a great thing. I think that is the crux of palliative medicine. Thank you. Thank you.
Thank you, sir. So we have a 57-year-old man who is diagnosed to have carcinoma of the hard palate, underwent palliative radiotherapy, but he had all the complications, oral mucositis, then palatal perforation with nasocutaneous fistula and the leaking of food materials. He had good family support, but the palliative care team was able to intervene properly with the support of community. So he could have a good quality of life, which is the essence of palliative care. So anybody would like to comment on those points regarding pain management, community support, and seeking solutions?
I think I should congratulate the team, sir. It's very heartening to hear such stories. And the main point that I have learned from here is when you know to address the pain from all aspects, just like we saw in the video, the total pain was addressed when the volunteers gave him support. The family support was, the volunteer team made the family understand why he needs support. Being in such pain, he was as good as gone was what was the initial comment of the wife. So from that point to bring the family to support him, I think the role of the volunteer service is really commendable. This is what I wanted to say.
May I add something?
Yes, sir.
The only point, the trouble with this friend of mine is that he is refusing to go back for a review. He says it's only the palliative team which cured his disease. We know it's not that, but he says I don't want to go there. If you like, anyway, there is no local recurrence. I am an ENT specialist myself, so I used to have whenever he comes, I remove the process and look at the local recurrence is not there, but preferably an endoscopy and all will be in our clinical setup. That's not. But he refuses to go back to. Anyway, I think in the days to come, we will be able to convince him to go for a review.
Okay, I think Dr. Anisha want to speak.
Actually, this is a very heart-touching story because especially in case of head and neck cancers, especially in palliative patients, usually it is the suffering is very high compared to other sites. The patient have a long survival, usually with head and neck tumors, but they will have a lot of issues like electrolyte imbalance, like due to the fistula formation, post-RT necrosis changes and all. But I think it is clearly mentioned, as Sir told, he has transformed to the stage. It is a very like some divine interventions can also usually in certain situations something beyond our limit. And so happy to hear this. And also, I think many of this won't try this palatal. Many I have seen many patients post-RT, they will have a necrosis and there is a nasofistula, which is usually not clearly managed. I think this can also, every time, usually we may not get good results, but still it is a very good option always, I think. Thank you, sir, for sharing such a nice experience.
We had to change that process 3 times.
Yeah,
it was very cooperative.
Yeah, okay, sir.
Anybody else?
Sir, can I?
Yes.
Sir, actually, this means like in this happy ending case itself is a great thing, according to me, because usually we see means mostly we in this condition or if we get the patient, it's like most as ma'am told and asserted, it's a happy ending. That's the biggest thing, and the process is like they got. I feel that the family got a great trust over the palliative the volunteers, because they asked the family, means they supported the family, like the daughter should come and stay with them. That will actually might have increased the trust in these people, and whatever they say, they might have got little more, like they might have obeyed whatever means according to sir's volunteers, whatever they're saying. And they have all the trust in these people, rather than, maybe more than the treatment place. Means what I feel according to this, because whatever they have told, they are obeying. Like the daughter came and stayed with them. The process they took, means they took the initiative for the to the dental college and all those stuffs, and the progression, the betterment of the patient also might have, like all trust goes to these people with the volunteer group. Thank you, sir. Thank you, Ravindra sir.
Anybody want to comment on the community support?
May I?
So what is he doing for his daily living now?
He was working with the Dinesh Bedi as a BD worker, then rose to become an overseer. He has been reinstated with them. He gets some job. He goes there. He can work. No, absolutely, he has no problem. Look-wise also has, except for a small hole near the middle canthus, he looks as good as all of us. He's great.
That is very nice to hear, sir. I would have developed
Only
his
only
self-esteem.
the recurrence only, that is the only thing.
As a pathologist, I have seen many recurrences, but I pray for this patient, especially that you will never have any recurrence. Yeah, thank you, sir.
I think he has all our prayers, sir.
Thank you. About the community involvement, I think the role is with the palliative team. The community, our community is very receptive, but somebody has to initiate. The palliative team has to initiate it. And most of the time, the family, the people around them, they want to keep it a secret. They don't want much people, but that should change. And there again, the palliative team can help a lot, I think. Don't you think so?
Yeah. So let me look at take the pain management. So sir told that they have given 2.5 milligram morphine for hourly. So we know that tramadol can be used, but around the world, many are now not using the WHO step ladder to, especially for cancer pain. So you can use small dose of morphine, and we will speak on opioids in the next class. But this is very important, because if you compare tramadol with morphine, tramadol is costlier, and the patient may not be able to afford if they are unable to go for any job. And this patient, all of you have told, address the total pain. So in addition to morphine, I think the prosthesis which made him very normal, and along with the family support and the community support, I think those were the few points that actually made him totally pain-free, or he is having a very good quality of life as of now. So the community involvement is very important, because as doctors, we can, or medical professionals, we can look into the medical aspect, like physical problems, how to relieve pain, how to relieve breathlessness, all those things. But if you involve the community, the magics like this can occur. They will find out some solution. Even prosthesis, they will find out somebody to sponsor, and they will help the family somehow. So this is very important, community involvement. If you involve them properly, they can be involved in the psychosocial and spiritual suffering. And seeking interventions or seeking for solutions. That was very good because sometimes every palliative care team may not be able to find out the solution for that looking into prosthesis. Sir, do you know the cost of that prosthesis?
Around 6,000 or something.
Okay.
We funded it. The
Okay.
society funded it.
Okay. So Dr. Shashidharan is asking, are we getting sublingual buprenorphine now? Okay, sublingual buprenorphine is available, but we usually don't use buprenorphine because all around the world, morphine is the gold standard, and buprenorphine is also a partial agonist. So it has healing effect for analgesia. So we usually don't use sublingual buprenorphine, and it is costly compared to morphine. So, are there any more points that you want to comment? Or any doubts? Anybody?
Thank you.
Okay, methadone is available. Methadone is available.